Now on to restrictive lung disease. As we mentioned just a couple of moments ago, restrictive lung disease has its own characteristic pattern on pulmonary function testing. Because you have restricted expansion, lung volumes such as forced vital capacity and total lung capacity are decreased. But what happens to the FEV1/FVC ratio? Unlike what I showed you with obstructive lung disease, the ratio is usually preserved. So here the patients don't typically have any problems emptying their lungs, they just have less volume to exhale. Now it's useful to think of restrictive lung disease in two ways. First, think of the mechanics of breathing and the different components involved that aren't the lungs themselves. There may be conditions that affect the respiratory muscles such as poliomyasthenia gravis, or you may have conditions that physically restrict the volume capacity of the lungs such as scoliosis and morbid obesity, which is really one of the more common causes of restrictive lung disease.
Interstitial lung diseases, which affect the lung parenchyma, are restrictive lung diseases that also negatively impact the diffusion capacity of the lungs, specifically lower DLCO.
ARDS and neonatal respiratory distress syndrome, which we will discuss shortly, both fall into this category, as do pneumoconiosis. There are also a bunch of drugs that can cause direct lung toxicity, fibrosis, and therefore restrictive disease. Can you think of any other in addition to these three? So to this list I would also add nitrofurantoin, cyclophosphamide, and methotrexate. And finally, here's a gross path image showing the honeycombing, that's typical of usual interstitial pneumonia, also sometimes called idiopathic pulmonary fibrosis. As I mentioned a moment ago, pneumoconiosis are a type of interstitial lung disease that can give you a restrictive disease pattern. Here, the pathology involves some sort of change to the normal lung parenchyma as a result of exposure and response to foreign substances. Coal miners' pneumoconiosis, or black lung, is obviously associated with exposure to coal and its byproducts. The inflammation and fibrosis typically affects the upper lobes. You can also see something called Kaplan syndrome. And what's that? Well, Kaplan syndrome is a mix of rheumatoid arthritis and pneumoconiosis in people with intrapulmonary nodules seen on chest X-ray in a homogeneous pattern. Silicosis is also known as Potter's rot or Grinder's disease. This is associated with exposure to the byproducts of mining such as foundries and sandblasting. In this disease process, the presence of silica causes the production of hydrogen peroxide and other oxygen radicals that damage the lung tissue. Alveolar macrophages take up these particles and release cytokines such as TNF-alpha, IL-1, and leukotriene B4, which can all lead to fibrosis. Silicosis is also associated with TB, which is board testable. Now, can you explain to me why that is without looking at the book? Alright, this is thought to be due to the silicone inhibiting the phagolysosomes and impairing the macrophages in people at risk for TB. Other complications of silicosis include cor pulmonale and Kaplan syndrome, as just discussed. Asbestosis is perhaps the best known pneumoconiosis, especially because of all those late night commercials. Attention! If you or a loved one have been diagnosed with mesothelioma, you may be entitled to financial compensation. Of course, the lawyers left out bronchogenital carcinoma, which is certainly associated with asbestosis. So what is asbestos? Well, it's a silicate mineral that was used for a lot of things, including insulation, fireproofing, and soundproofing. Therefore, you would typically see exposure in such industries as shipbuilding, roofing, plumbing, and so forth. Unfortunately, exposure classically causes these calcified pleural plaques. And in particular, these straight fibers are more carcinogenic than the curved ones. Now, unlike the other pneumoconiosis that we just talked about, asbestosis typically affects the lower lungs. Here we see some asbestos bodies. These are also known as ferruginous bodies as well. And basically they're asbestos fibers that developed a ferritin protein coat with a dumbbell or beaded appearance. Alright, remember from our discussion of pulmonary physiology that surfactant is produced by type 2 pneumocytes, and that surfactant itself is important for decreasing alveolar surface tension, increasing lung compliance, and therefore decreasing the work of breathing. So the importance of surfactant is highlighted in neonatal respiratory distress syndrome, where the pathology is related to the neonate's lack of surfactant. This deficiency is due to the immaturity of the neonate's lung, which leads to increased surface tension, decreased compliance, increased work of breathing, and alveolar collapse. Preterm infants, especially those younger than 35 weeks, are at higher risk. Other risk factors include diabetes and C-section. A key marker of lung maturity is the lecithin to sphingomyelin ratio in the amniotic fluid. Lecithin is essentially dipalmitoyl phosphatidylcholine. Both lecithin and sphingomyelin are lipids and surfactant with other lipids and apoproteins. In neonatal respiratory distress syndrome, the LS ratio is generally less than 1.5, whereas a ratio of 2 or greater indicates a lower risk of neonatal respiratory distress syndrome. Now, survival tends to be poor in neonates younger than 24 weeks. Treatment strategies typically include administration of maternal steroids before birth to hasten lung maturity, intraalveolar administration of artificial surfactant after birth, and CPAP or continuous positive airway pressure, or even intubation with oxygen. In spite of these measures, neonates may remain in critical condition for months and are subjected to the consequence of not only immature lungs, but also the complication of too much oxygen in the perinatal period, which can result in retinopathy and bronchopulmonary dysplasia. Acute respiratory distress syndrome, or ARDS, has a number of causes related to illness or acute injury, as listed here. In addition to these causes, I would also add massive blood transfusion. ARDS typically starts off as a patchy process that involves inflammatory cells like neutrophils or some T cells. Cytokines contributing to lung damage include TNF, leukotrienes, and macrophage inhibitory factor, or MIF. In this histopath image on the right, you see inflammation, edema with proteinaceous fluid, and hyaline membranes, which is this glassy pink appearing material when you stain with H&E. So here's a bit of board trivia. In which condition were hyaline membranes first observed? Actually, it's neonatal respiratory distress syndrome, which we just discussed. In fact, NRDS is also known as hyaline membrane disease. And in fact, this particular image could pass for NRDS. Management of ARDS has gotten better, but it's still a deadly condition. Mortality rates used to be as high as 70%, but now have dropped into the 30s. Patients typically require mechanical ventilation over a long period of time with low tidal volumes. However, during the course of treatment, oxygen radicals from high FiO2 levels can cause diffuse alveolar damage. Okay, we just looked at NRDS and ARDS as examples of restrictive lung disease. Now let's go back and compare obstructive and restrictive lung diseases to recap. Over here, you see an example of normal lung spirometry where the ratio of FEV1 to FVC is approximately 80%. Obstructive lung conditions, as you see here, have lung volumes that are higher than normal because of the air trapping. Specifically, you see increases in total lung capacity, functional residual capacity, and residual volume. And again, the FEV1/FVC ratio is less than 80%. So how would you contrast this with restrictive lung disease? Obviously, you can see a big decrease in volumes, but even though there's a decrease in FVC, you also get a big decrease in FEV1 as well. And this results in an FEV1/FVC ratio that is greater than 80%. Sleep apnea is becoming a more common board topic, especially as the prevalence of obesity increases. An apneic event is defined as cessation of breathing for at least 10 seconds. When this occurs in obstructive sleep apnea, which is the most common type, the respiratory efforts continue against airway obstruction. Because you have alveolar hypoventilation and hypoxia, you can get secondary polycythemia from erythropoietin release and pulmonary artery vasoconstriction in an attempt to shunt the blood with resulting pulmonary hypertension. So does this phenomenon remind you of anything? Well, it should make you think of COPD, which we just talked about, where you see the same complications. You can also see some right heart strain, as well as the development of associated arrhythmias. So the risk of sudden death is very real for these patients with sleep apnea. Now, even before this, however, are the symptoms of chronic fatigue. So keep in mind the 3 S's for obstructive sleep apnea, which includes snoring, sleepiness, and then finally, significant other who is witnessing the sleep apneas. Central sleep apnea is less common and involves the absence of respiratory effort due to a failure of stimuli from brainstem command centers. Well, what causes sleep apnea? Well, things to keep in mind include narcotics, bad heart, renal failure, or a recent ascent to high altitudes. Now, in terms of treating sleep apnea, you can consider weight loss, continuous positive airway pressure, or airway revision for obstructive sleep apnea. And with central sleep apnea, you have to treat the underlying pathology, in addition to supportive care with CPAP.